morning to everyone. I am Dr. Tharani from Sri Balaji Dental College and Hospital, Department of Oral and Maxillofacial Surgery. Today I am going to talk on pre-prosthetic surgery. Pre-prosthetic surgery. Pre-prosthetic surgery is refers to a surgical procedure that can modify the theoretical anatomy to facilitate the retention of the conventional denture. According to the glossary of prosthodontic term, pre-prosthetic surgery is defined as a surgical procedure designed to facilitate the fabrication or to improve the prognosis of prosthodontic care. According to the Bruce Roloff, pre-prosthetic surgery is the part of the oral and maxillofacial surgery designed to establish the best soft and hard tissue base for prosthetic appliances. The objective of pre-prosthetic surgery is to eliminate the disease, conservation of oral structure, provide the residual tissue to withstand masticatory force, maintain function and aesthetics. Alveolar atrophy. The term alveolar atrophy is referred to the regression of the teeth supporting prism shaped osseous part of the upper and lower jaw. It caused by periodontal disease, trauma, patient factor like age, gender, skeletal and morphological function, endocrine and metabolic disorder like hyperparathyroidism, calcium deficiency, dietary consideration and mechanical factors like extraction, removal denture, hearing aid, combination symptom. Pattern of bone loss. The result of Tharani study indicates that the change under the denture base more often occur in the mandible. The difference in the resorption of the jaw increases within the first year of denture wearing, which proves that the mandible cannot resist the strong bite force under the denture base. According to the Clements, initially resorption starts on the alveolar part of the mandible and the rest of the mandible remains unchanged. Resorption is faster in the labial and buccal part of the alveolar ridge. Resorption changes of maxilla and mandibular bone structure. Alveolar atrophy is classified by 4 classes. Class 1 is characterized by the alveolar ridge adequate in height but inadequate with width, usually with the lateral deficiency or undercut area. It can be treated by hydroxyapatite alone. Class 2 is characterized by alveolar atrophy deficiency in both height and width and has a knife edge appearance. It can be treated by hydroxyapatite alone. The alveolar atrophy is resorption to the level of basilar bone producing a concave form of posterior area of the mandible and the sharp bony ridge forms with the mobile soft tissue in the maxilla. Hydroxyapatite alone or a mixed with the autogenous cancellous bone can be treated. In class 4, resorption of the basilar bone producing a pencil thin, flat mandibula or flat maxilla. Hydroxyapatite mixed with the autogenous cancellous bone. The modification of class 2, no wall defect, buccal wall, multi-wall defect, and in class 6 is a marginal resection and continuity defect. The functional effect of edentulous. The maxillomandibular relationship is altered in all spatial dimension. Progression towards a decreased overall lower facial height lead to the typical over-closure appearance. Progressive instability of conventional soft tissue. The ideal denture base has following character: adequate bony support, soft tissue coverage, no undercut or protuberance, no sharp ridges, adequate sulci, absence of peripheral scar band, no muscle fiber to the mobilized prosthesis, no soft tissue fold, hypertrophy, no neoplastic lesion, proper maxillomandibular arch relation, adequate palate valve, tuberosity notch. Diagnosis and treatment planning of pre-prosthetic surgery is initially with history taking, chief complaint finding, medical history evaluation, and physical examination and soft tissue evaluation. Hard tissue evaluation and finally with the investigation by means of radiographic and lab diagnosis, and the patient selection is by the general physical status, age and anatomical factor. Pre-prosthetic surgery are classified by 3 ways: ridge correction, ridge extension, ridge augmentation. Alveoloplasty or a ridge correction surgery, mylohyoid reduction, tuberosity reduction, gene tubercular reduction, removal of Tharani, removal of exostosis, removal of undercuts. In a ridge extension, Vestibuloplasty were done, and ridge augmentation, maxilla and mandibular ridge augmentation can be carried out. In soft tissue, Freenectomy, Vestibuloplasty, excision of epulis fistulata, excision of palatal papillary hyperplasia, and removal of redunculate crystal soft tissue. In Freenectomy, labial Freenectomy and lingual Freenectomy are done, and Vestibuloplasty, submucal Vestibuloplasty, maxillary Vestibuloplasty, lip stitch Vestibuloplasty, and mandibular Vestibuloplasty, and floor of mouth lowering procedure. Alveoloplasty is defined as a surgical recontouring of alveolar process. This was first in 1853. Villiard removed the interdental papilla, permitting the edge-to-edge closure. Where in 1876, radial alveolectomy was done. Devon in 1930 tends towards the conservatism had behind. Moulton in 1923 used the study cast to plan the alveolectomy, and Deans in 1936 intercepted alveoloplasty was performed. Obswecker in 1966 modified the Deans technique, and Michaels and Borsons in 1976 studied the postoperative resorption. The principle of alveoloplasty are optimal ridge contouring, permitting early construction of the denture, broad alveolar ridge, reduction of the irregularity, rounding of the sharp ridges, preservation of cortical bone as much as possible before surgery from 4 to 6 weeks in case of severe periodontitis. Alveoloplasty are classified into 5 types: alveolar compression, simple alveoloplasty, labial and buccal cortical, Dean's interceptor alveoloplasty, obs-Wester technique. Alveolar compression. Easiest and quickest method involves in compression of cortical plate with a finger, reduction with socket. Alveoloplasty is defined as a reconstructing of alveolar process. Indicated is patient with prominent and dense alveolar bone undergoing extraction. Prior to the construction of immediate denture, the simple form of alveoloplasty consists of compression of the lateral wall of extraction socket after the simple tooth removal. Bony area requires a recontouring should be exposed using an envelope type of flap. The mucoperiosteal incision along the crest of the ridge with adequate anterior-posterior extension is given. Adequate visualization and accessibility to the alveolar ridge is attained. The vertical incision give if necessary. Excessive flap reflection is resulting in devitalization area of the bone, which may resolve rapid after the surgery. Recontouring can be accomplished with ronger, bone file, bone work in handpiece. The copious saline irrigation should be done throughout the recontouring procedure to avoid the overheat of the bone to cause necrosis. After this, edge of the flap is trimmed and it's sutured with continuous or non-continuous suture. Ronger, bone work and bone files are highly used. Simple alveoloplasty is indicated in reduction of buccal and labial plate, extraction of single and multiple tooth. This technique are simple tooth extraction, multiple tooth extraction over erected tooth. Labial and buccal cortical alveoloplasty. Dean's intercortical crush techniques. The principles of reduction of labial and alveolar prominence. The muscle attachment is disrupted. Intactor periosteum. Preservation of cortical bone. Less post-operative resorption. Dean's interceptor alveoloplasty is a technique best used in the area where the ridge is relatively regular contouring and adequate height but presence of undercut to the depth of the labial vestibule. Performed during the time of extraction, the advantages of Dean's interceptor alveoloplasty is labial prominence is reduced without reducing the height of the ridge. The periosteal attachment to the bone can be maintained here by reducing the bone resorption. The muscle attachment are left undisturbed. The disadvantage of Dean's interceptor alveoloplasty is decreases the ridge thickness. Indications of Dean's is immediate denture, quadrant extraction. Obs-Wester techniques in 1966 indicated highly in the pre-maxillary protrusion. Knife edge ridge reduction is extremely resorbed, resulting with sharp or pointed ridge at the cut into the mucoperiosteum on the pressure application. The pain occurs on wearing denture. This is a mylohyoid ridge reduction is first reduced if there is same high level than the alveolar bone. Robsters in 1977 reduces the mylohyoid ridge and extension of posterior lingual denture flanges into the retromylohyoid fossa. Hose in 1964, mylohyoid ridge reduction is the most useful single operation. Mylohyoid ridge reduction is a linear incision or made in the crest of the ridge in the posterior aspect of the mandible. The full thickness mucoperiosteal flap is elevated to expose the muscle. The bone files are used to remove the sharp prominent mylohyoid ridge. Maxillary tuberosity reduction. The excess tissue in a region of maxillary tuberosity may become so large that it impinges upon the mandible during the mastication, the interference of the denture, construction, insertion and seat. The complication of the tuberosity reduction is extended tuberosity proximal to the sinus. The maxillary tuberosity reduction is impinges upon the mandible during the mastication, interference with the denture construction, inserted and seated. Expansion of tuberosity in a proximity in sinus. Three techniques of genial tubercular reduction are removal of tubercles following by the allowing genial muscles to detach on its own. Removal of tubercles followed by repositioning the muscles with suturing fastened to the chin. Removal of tubercles followed by the transposition of muscle to the interference tubercle. Tharani removal. In the patient requiring a complete or partial conventional prosthetic restoration, Tharani may be significant obstruction in the insertion of interference with the overall comfort, fitness, function and planning of prosthesis. In the maxilla and bilateral, greater palatal and incisive blocks are given. A linear midline incision with the posterior anterior vertical relieving of U-shaped incision of a palatal followed by subperiosteal dissection is used to expose the defect. The rotary instrument with the round acrylic burr may be used for a small area, however the large Tharani, the treatment choice of resection of cross-cut fissure burr is used. Once sectioning into several pieces, the torus is easily removed with the osteotome. The closure is performed with the resorbable suture. The pre-surgical fabrication of thermoplastic stent made of dental model with the defect removing in combination with the tissue conditioner helps to eliminate the result dead space, increase the patient comfort. The complication of Tharani is post-operative hematoma, perforation of the floor of the nose and necrosis of flap. Mandibular Tharani. Mandibular Tharani is a exostosis found in the lingual surface of the mandible opposing the canine and the premolar region. They are present in the 8% of population with the equal frequency of male and female. Usually bilaterally 80% of affected may be a single or multilobular. Etiology was unknown. The functional reaction is to masticatory force. Mandibular Tharani in bilaterally, it initially started with inferior alveolar nerve. Anesthesia was given. The incision extended to the 1.5 mm beyond the Tharani each is given. Always leave behind the band of the tissue attached to the midline between the anterior extension of the two incisors. When the Tharani has a small pedunculated base, mallet and the osteotome is used to cleave the Tharani from the medial aspect of the mandible. The direction of the initial burr is parallel to the medial aspect of the mandible to prevent the fracture of lingual or inferior cortex. A bone file is then used to smoothen the lingual cortex. The palpation is done, check for the proper contouring and the presence of any undercuts. The continuous suturing is done and gauze pack is placed and retained for next 12 hours. The direction of the initial burr is parallel to the medial aspect of the mandible to prevent the fracture of the lingual or inferior cortex. The bone file is then used to smoothen the lingual cortex. The palpation is done to check the proper contour and presence of any undercut. Continuous suture is done with the gauze pack is placed to retain for 12 hours. Indication of removal. Tharani causes a lingual undercut and interference with the lingual flanges extended to the planning of prosthesis. When the mucosa is covered the ulcer, large Tharani interference with the speech and deglutition. Palatal Tharani removal is itself an outgrowth of the midline of the shapes and etiology was unknown. The composition of cortical bone may result in cancellous. The technique position of rectal backward. The complications are hemorrhage, hematoma formation, nasal and antral perforation, slough and necrosis of the palatal tissue, fracture of palatal nerve. Palatal exostosis found in the maxillary molar region, preservation of the vascular supply and main concern during surgery. Lateral palatal exostosis present problem in a denture construction because of the undercut created by the exostosis and narrowing of the palatal valve. The technique are injection of local anesthesia solution in the greater palatal foramen. Crystal incision was made in the posterior aspect of tuberosity extended to the exostosis. Reflection of the mucoperiasteum, removal of the excess bony undercut of the bone file, saline irrigation was given and suturing done. Buccal exostosis. The causes of resorption of a apical area is treated with excision or filling of undercut. What is frenum? Frenum is a fold of mucous membrane with the enclosure of muscle fibers and attached to the lip to the alveolar mucosa of the periosteum. Frenulum is a small frenum. There are several frena that is usually present in the normal oral cavity. Most noticeable of maxillary labial frenum, the mandibular labial frenum and lingual frenum. Their primary function is to provide the stability of upper and lower lip and the tongue. Type of frenal attachment are mucosal, gingival, papillary and papillary penetration. The treatment are freenectomy, frenotomy. Freenectomy is referred to the complete removal of frenum, including its attachment to the underlying bone. It is required to correct the abnormal diastema between the maxillary central incisor. Frenotomy is an incision of the frenum. It is usually done to relocate the frenum attachment so as to create a zone of attached gingiva between the gingival margin and the frenum. Technique of freenectomy are conventional freenectomy, Miller technique, VY technique, Z-plasty, freenectomy by using a electrocautery and laser freenectomy. Freenectomy of scalpel. Vestibuloplasty. Vestibuloplasty is a surgical procedure whereby the oral vestibule is dependent on the changing of soft tissue attachment. Vestibuloplasty is a sulcoplasty, sulcus deepening procedure. Type of vestibuloplasty are mucosal advancement, P-plasty, secondary epithelial vestibuloplasty, grafting vestibuloplasty. Mucosal advancement vestibuloplasty is to extend the vestibule to provide the additional ridge height, to excise the tensor of submucosa, congenital tissue and adjuvant muscles to the position farther from the crest of the ridge to prevent relapse. This procedure is especially applicable to the maxillary vestibule where better result of attained. The success of mucosal advancement B-plasty depends on the availability of adequate bone, sufficient amount of freely movable mucosa. LA is administered. Vertical incision was made along the mucogingival junction with the lip. With the lip is everted, the horizontal plane of scissor is introduced to the incision. By the blunt spreading of dissection of the mucosa, separate the submucosa on the right and left side. The tunneling is formed between the mucosa and submucosa extended from the mucogingival junction into the cheek and lips, so the mucosa is completely underneath. The tunnel is carried out posteriorly until the zygomatic buttress to be mental area of a mandible. Additionally, vertical incision was made to the premolar and molar region of the posterior dissection. Now the vertical incision is dependent to the periosteum at the midline. The muscle and periosteum is attached to the periosteum of a supraperiosteal dissection using a scissor. The wedge tips of connective tissue remains between the two tunnels. The freely movable mucosa is adjuvant to the depending of the sulcus. The vertical incision is suture. The roll gauze is placed to the vestibule, supporting the mucosa temporarily. The component impression was made extend to the vestibule using the patient denture or by a splinter. A new denture was usually be made within 3 to 4 weeks. Open view of submucosa V-plasty. Vallius proposed the open window view of instead of tunneling. The horizontal incision was made along the mucogingival junction of the mucosa only. The mucosa is dissected from the submucous far out from the lip. Large flap of mucosa is mobilized. Supraperiosteal dissection then is performed into the desired extension of proposed vestibular extension. The stay suture of placed in the flap to fix it. The periosteum dip deep into the vestibule. The free margin of the flap then return to the original position and suture. Secondary epithelialization of the vestibuloplasty. It is indicated when the sufficient bone is present but the mucosa is either insufficient in a quality or by poor quality. Types are Cassangian technique, Lipsis technique and Clark's technique. Cassangian technique, an incision was made in the mucosa of the lip. Large flaps of labial and vestibular mucosa is reflected. The vestibule is deepened by the supraperiosteal dissection. The flap of the mucosa is turned downward from the attachment of alveolar ridge. The flap is placed directly against the periosteum to which the suture is done. The rubber catheter stent is placed into the deepened sulcus and fixed throughout the lip of the outer surface with the stage of healing. The catheter is removed after 7 days. The labial donor is coated with the teenage benzoate compound and left the granulation by the secondary epithelialization. Lipsis technique, it is a variant of Cassangian technique. And this mucosa flap is developed same way the suggestion of Cassangian. After the reflection of the mucosa flap is the crystal alveolar ridge, the periosteum is incised high on the alveolar ridge. Now the periosteal flap is containing the connective tissue and the muscles transposed outwardly. The periosteal flap is sutured to the raw wound on the lip. Then the mucosa flap is turned downwards against the bare bone and suture the periosteum deep to the vestibule. Thus the vestibule is lined by the osseous side of the mucosa and labial side of the periosteum. The new epithelial surface is grown in the periosteal surface of 2 to 3 weeks. Clark's technique, this can be considered as a reverse of Cassangian technique. Clark based in this technique 4 principles: raw surface on the connective tissue and raw surface overing the bone. Epithelial flap of the undermining sufficient permit the repositioning and fixation of without tension. Soft tissue undergoing plastic revision surgery. In this, the alveolar ridge and the supraperiosteal dissection was made in the depth of desire. Mucosa of the lip is undermined until the verular border. 3 non-observable percutaneous suture was placed. The free margin of mucoperiosteal flap carried out in the skin and tied over the cotton wool. The soft tissue side of the vestibule is covered with the mucosa, where also osseous side of the raw periosteal surface of the left granulation of the epithelium. Lingual vestibuloplasty, it is used in the mandible. There are 2 techniques, Cladwell technique and Turner technique. Turner technique is used to increase the depth of the floor of the mouth of the mylohyoid ridge. Bilateral incision was given from second molar to the second molar. Supraperiosteal dissection was done. Instrument is passes below the mylohyoid muscles to separate the bony attachment. The fixation of the incisal edge of the mylohyoid muscles, new desired depth of the lingual side is done. Placement of the skin graft and performed chest. Cladwell technique is either a lingual mucoperiosteal flap is reflected from the molar to molar region. Mylohyoid ridge is reduced and removed along the direction of the genial tubercle. Mylohyoid muscles and the superficial fiber of the genium are crosses and pushed inferiorly. Rubber tube is placed lingually, vestibular and and suture passes through the skin extraorally. Orbs flexor technique, combination of the buccal and lingual vestibuloplasty. Incision is given in the alveolar ridge. Mucosa flap is elevated in the buccally and lingually. Mylohyoid muscle attachment is only the superior fibers of the genioglossus muscle is separated on the lingual side. Edge of the buccal and lingual flap attachment suturing on either side below the inferior border of the mandible. Grafting vestibuloplasty indicated in when there is an inadequate amount of bone component elapsed after the vestibuloplasty. When bone graft is being placed in the surgical site, when the large surgical defect would be at the site. The principle of skin graft, the skin graft, thin skin graft and recipient site. Ridge augmentation. Ridge augmentation indicated in the progressive loss of a denture, stability and retention, loss of alveolar ridge height, width and decreasing the vestibular depth and denture bearing area. Increase the susceptibility to fracture of the atrapizia, replacement of the necessary support bones, altering the intra-articular relationship. Ridge augmentation, maxillary augmentation, onlay bone grafting, interpositional sandwich grafting technique. Mandibular augmentation is the superior border augmentation, inferior border augmentation, interpositional augmentation and onlay grafting. Mandibular augmentation. Augmentation of grafting added center to the extremely deficient mandible to improve the height of the contour available in the bone. Implant placement on the denture bearing area. The source of the graft material is autogenous, hologenous bone and alloplastic bone. Mandibular bone augmentation is by means of classified into superior border augmentation, inferior border augmentation, and hydroxyapatite augmentation and osteopromotion. Superior border augmentation, stoma and whole hand technique. Corticocancellous iliac twist block are contour adapted to the configuration of the mandible, then fixed to the screw and mini plates. Hydroxyapatite augmentation, osteopromotion. Osteopromotion, a membrane is used to cover the area where the bone regeneration is necessary. By placing the membrane over the bone graft, faster the growing the fibroblastic and epithelial cells are dilated off, allowing the bone to grow in relatively flexibility. Currently expanded, the polytetrafluoroethylene is used as a membrane. Material used for augmentation or graft. Portion of the tissue or an organ that after removal from the original or a donor site, positioning instead of the different placement of the objective reinforcement existing in the tissue or the correction of structural defects. Classification of augmentation according to the structure, according to the source, and according to the environmental factor. It's as cortical cancellous and cortical cancellous, autograft, allograft, mesoglaft, allograft, and membranous and endograft. Autogenous graft are distant sites and local sites, rib, iliac, calvarium, fibula and tibia, shin, body, ramus, ligamentiversus and paw. Advantages and disadvantages of bone grafts. Mandibular augmentation, the superior border of the mandible was given by Davis in 1970, indicated for remaining bone less than 10 mm. Ability of the patient to tolerate the procedure, donor consideration and recipient site. Augmentation of the inferior border of the mandible indicates the remaining less than same as of maxillary augmentation. Advantages are no vestibular obliteration, no dehiscence, less pain, better fracture stability, 20 calculoplasty not required, bone resorption, less bone resorption, indicated for the pencil thin ridges. Disadvantages are scarring, presence of loose submandibular tissue, do not correct the superior irregularity. Mandibular augmentation or by means of horizontal and vertical osteotomy. Mandibular horizontal osteotomy is indicating the reasonable amount of bone above the mandibular canal between the dimension of less than 12 to 15 mm. Vertical osteotomy is a visceral osteotomy, the little bone above the mandibular canal. The combination of vertical and horizontal osteotomy is less risk of fracture, better superior post repositioning of the segment. Correction of the mild moderate anteroposterior discrepancy increases the amount of augmentation. This technique is Stallman modification. Maxillary augmentation. Maxillary augmentation, on-day bone grafting, interpositional bone grafting, hydroxyapatite augmentation, sinus lift. Sinus lift is an extension of the maxillary sinus into the alveolar ridge, may prevent the placement of the implant in the posterior maxillary area, causes the insufficient bone support. The grafting is allowed to heal 3 to 6 months, after which the first stage of implant placement can begin. Ridge augmentation, augmentation with the synthetic graft material. Hydroxyapatite is a prototype of the non-resorbable ceramic bone substitution. It is a calcium phosphate material having the physical and chemical characteristics nearly identified and the dental, enamel and cortical plate. Techniques. Advantages are simple surgical technique, no donor site is required, hydroxyapatite are used, Vestibuloplasty extrusion is done, metallic implant system has used. Complications are dehiscence with the extrusive particle, abrasion throughout the mucosa in the extrusion, infection, abnormal color and mental neuropathy. Augmentation using mesh. The membrane is designed to prevent the filtration of the particles graft, which the connective tissue and the hollow bone infiltrated the graft rather than the formation of sufficient bone. Disadvantages are premature exposure and infection. Manipulatory. Vertical augmentation with the distraction osteogenesis and in the latency period of 5 to 7 days, distraction period of 0.5 to 1 mm in 1 to 4 times, and consolidation period of 8 to 12 weeks. Alveoloplasty bone graft osteotomy device is breast transport segmented with remains in the restriction period of 0.5 to 1 millimeter a day per day to 1 to 4 minutes 4 times. Bone is segmented subjected to the traction, activation of tissue growth and regeneration. In a consolidation period of 8 to 12 weeks, the formation of distraction callus and maturation into a bone. The indications are the moderate to severe alveolar bone defect, segmental deficiency, adjuvant to the other graft, less between the width of ridge. The vertical augmentation limitation, advantages and disadvantages. A simple less resorption including a teeth and implant in transport segment with a less time. Thank you.